this webinar on the occasion of celebration of 40th ISSP Foundation Day by Society for Study of Pain, Pune. And I really welcome you all. And we are 50. So yes, right time to start. I would like to call upon our dear President, who's recently taken over as a President of Pune Pain Society, to welcome you all and have a word. Yes, Dr. Varshali Kenya.
Thank you, Varsha. Thank you so much. Yeah, on behalf of Society for Study of Pain, Pune, I welcome you all for this academic session on ablative techniques, various ablative techniques in pain medicine. We have today very eminent speaker, Dr. Gautam Das sir, Dr. Dhruva and Dr. Uttam. You all know that SSPP is very enthusiastic in arranging all these academic webinars with lots of discussions. And this, I promise you that this trend will go on in next few months also. So without wasting much time, I would like to request Varsha to continue the session, to go ahead, because everybody is eager to hear the eminent speakers. Yeah, Varsha, over to you. In the meantime, till Dr. Kiran has his all the adjustment, this webinar will have 20 minutes discussion, presentation and 10 minutes discussion. Is that right, Varsha? You are on mute.
Yeah, everyone is on mute. Okay, I muted everyone. So let us start. As I was saying, I have muted everyone, and as and when required, I'll unmute the respective person. Okay, so let me unmute Dr. Kiran and Dr. Dhruva. Right.
Can you hear me?
Yeah. Very much loud.
Okay.
And am I audible? Someone had posted in a chat, Dr. Ravi. Yeah, thank you, Dr. Dhruva. So let us proceed. I would like to welcome Dr. Kiran Shete, Director of Spinalogy Clinic. He's recently celebrated the 16th anniversary of his clinic in Pune. And he's a very eminent pain physician practicing pain in Pune since 16 years. So I would like to welcome Dr. Kiran as a moderator for today's session. He will introduce the speakers and mediate the discussion. Okay, Dr. Kiran.
Yes, thank you, Dr. Varsha, and I really
recording in progress.
I really apologize for delay in joining this conversation here. So today's topic is very interesting, considering that radio frequency ablation is one of the very important tools in our armamentarium, considering that we get patients who are in chronic pain. And we are going to have very eminent speakers with us. And first we'll start with Dr. Dhruva. Dr. Dhruva is a consultant with Delhi Pain Management Center, and he's a fellow of he's FIPP from WIP, as well as he has fellowship in pain medicine from Germany. He's member of ISSP as well as renowned most of the pain organizations. A member of editorial board Indian Journal of Pain and Bangladesh Journal of Pain. As well as he has been organizing a wonderful conference every year since last 8 years about India Pain Update. So I welcome Dr. Dhruva and request you to start your presentation and give us updates on ablation techniques.
Sure, sir. Can you please allow me to share the screen, ma'am? Can you make me the co-host, please?
Yes, you are already co-host. Please share the screen.
Just. So can somebody just confirm that
Yeah, your screen is visible. You are nicely audible.
I am. Screen is visible. I am audible.
Yeah.
Yeah. So thank you so much. Good evening, everybody. Thank you so much, Dr. Varsha and Dr. Vaishali, for giving me this opportunity. And when I was preparing it, I was just thinking that whether it is pain or politics, the maximum news or maximum happening is happening in the wonderful state of Maharashtra. So thank you so much for the kind opportunity as well as on giving me this topic. Kiran sir, thank you so much for a very warm and a very elaborate introduction. But one thing I think you missed, which is the most important, that I was and I am an ardent student of pain medicine. So thank you so much for this opportunity. So let us start. Now, there are few principles of interventional pain medicine. This is how I look at them. There are two. One is the sniper theory. How I like to explain it is that pain medicine is all about identifying the pain generator and taking help of the best of technology to deposit the most potent and the most effective drug at the site of pain. So that is one. Second thing is, I have seen a lot of people talk about that this particular intervention didn't work, or this is not the right intervention. What I feel is intervention doesn't go wrong if we follow the 3 R's: right candidate, right intervention, and right timing. Along with that, I would like to also add right doctor, right training, and right experience. So if you follow any these two principles of sniper theory, where you are trying to pinpoint the pain generator and then selecting the right patient, right time, will in a properly trained hand, no intervention can ever fail. Moving on to today's topic of ablation, there are few general principles of ablation that we need to keep in mind. First, never first. Any ablative technique is never the first choice or the first line of treatment. We start with pharmacology, drugs, conservative. Even when it comes down to intervention, it is not the first line. Even if, for example, in a patient of, say, trigeminal neuralgia, where the patient eventually is going to undergo an ablative procedure, there also, or for example, the median branch which we will be discussing, it is always preceded by a diagnostic block. That is one. Second thing is, you need to have a clear understanding of anatomy. There are no two ways about it. Where the nerve is coming, what is the direction of the needle. When you are giving some liquid in the form, or you are going for a chemical neurolysis, there again you can have some margin of error. But when we are talking about technologies like radiofrequency, like cryoablation, you have to be extremely crystal clear about the anatomy. Precision is the key. Remember the first principle. Every shot is a sniper shot. Take all the time in the world to identify, but when you shoot, it has to be effective. Last point is, I'm often, whenever I interact, people always say my intervention failed in the OT. Intervention never fails in the OT. Intervention always fails in your consultation room. If you do not prognosticate the patient what he or she can expect in that particular intervention, then, my dear friends, you are bound to fail. Radiofrequency is no exception, because we are doing this in patients, firstly, who are quite challenged when it comes down to managing. Secondly, we are doing a diagnostic block. Now, what I have seen is, I really find it difficult to make the patient explain, to make the patient understand that what he or she is supposed to reflect or the consequences of doing a diagnostic block. So when I tell them it is going to last for 2 hours, and then only we go ahead. So prognostication is extremely important when we are doing these ablative procedures. Now, basic principle of radiofrequency. So now let us talk about that. So what is radiofrequency is all about? Now, in radiofrequency, what we are basically doing is, we are using the electricity, converting it into radio waves. When radio waves do an oscillation, there is production of heat. Once the needle is heated, the surrounding tissue gets heated. Once the tissue gets heated and the temperature goes beyond 42-45 degrees Celsius, that is the time when the protein starts to denaturate, or there is a destruction in the proteins, which eventually leads to the nerve being non-functional, preventing the transmission of impulses, which in this case is the painful or the nerve which is troubling us. So how do we produce it? It is a simple thing. We put the electricity, it passes through the body, and then we have an earthing pad through which the circuit is completed. The simple mechanics of or the simple laws of physics are the ones which are being followed. Now, the important thing, as we are the ones who are doing this intervention, this is extremely important when I talk about that you should have an earthing electrode so that your circuit is complete. Try to follow the same principles what you are following when you are using an electrocautery when in the OT. Because if the circuit is not complete, firstly, the radio frequency, the procedure itself becomes ineffective. Secondly, if there is not proper attachment, then there are chances, or there are case studies where they have gone ahead and had burns. So both for the effectiveness and to avoid complications, you definitely need to have a proper earthing electrode. Now, this is a basic setup. I won't be going into detail because of the time, but basically you have this electrode. This is the RF needle. This black part is the one which is insulated, and this is the active tip. Now, these needles comes in various shapes and sizes. Along with that, even the active tip, the part which is actually producing the radio frequency waves, and which will be responsible for creating the lesion, that size itself is also very variable. So it comes from the size of 5 centimeter, 10 centimeter, 15 centimeters. Active tip can be 5 mm, 10 mm. Along with that, it can either be a straight or it can be a curved needle. Now, what we are interested in basically is creating a lesion. So there are certain factors which will determine about the size of the lesion. One is the size of the electrode. Second is the temperature the temperature. Third factor is the time, and fourth factor is the tissue. Most of them have a direct relationship. For example, if we increase the size of the electrode, the lesion size will increase. If we increase the temperature, again, the lesion size will increase. If we increase the time for which we are producing a lesion, the lesion size will increase. But it is not that, or that we can do it indefinitely, because what eventually happens is when you start, the needle gets heated, the tissue gets heated, and after a point of time, if we keep on doing it, there is a charring or the burning of the tissue, which will act as an hindrance for the transmission of temperature across the tissue. Hence, the lesion size will be limited. Therefore, what they have found out is that, and that is one. Second thing is, while you can use a large size electrode, but in that case, the dissipation of heat will be all over the place. We want a concentrated amount of heat being produced to cause a reliable lesion. That is why a decent sized needle based on the lesion, along with temperature, and what they have said is around 80 degrees Celsius is the optimal or the sweet spot for realizing the lesion size. When it comes down to temperature, the time, they say 60 to 90 seconds. So that is why most of you would be doing it, or you would have seen somebody do it. We generally go for cycles. We go for cycles of, say, 60 to 90 seconds. Starting generally, I will start off by 60, 70, 80, probably 80, and I'll just try to change the direction of the needle and try to do a couple of cycles. Sometimes 90, but 90 again is not supported by the literature. What they talked about is 60, 70, 80, and 60 seconds to 90 seconds. Tissue characteristics. Now, that is again very important. Now, the the beauty or the effectiveness of radiofrequency lies when that active tip is in close proximity to our target. Therefore, it has to be close enough toward the target, but at the same time, it should not be close to a CSF or a blood vessel, because in that case, the shape of the lesion gets distorted and the predictability of the lesion is grossly compromised. So the larger size are created by high temperature, longer lesions. Now, this is something which I really want everybody to concentrate. Now, why I have been repeatedly trying to talk about and emphasize the importance of precision. We want the temperature to go beyond 45 degrees Celsius. The temperature that we set in the machine is the temperature of the active tip. But we want the tissue temperature to go beyond 45 to create that lesion. Therefore, we want the target nerve to be closed at this yellow or the orange lesion. That is one. Second thing, which is that the nerve has to be in direction with the active tip, because you can appreciate it is like a candle and you need to be in the yellow or the orange zone for the lesion to take place. So how do we do it? Firstly, we identify the nerve which we need to go for. That is one. Second, we identify either fluoro, ultrasound, depending upon your indication. We make sure the cannula is at the site. We confirm this position. This has to be precise. There are no two ways about it. Then we go for sensory and motor stimulation. Sensory, to be sure that we are close enough towards the nerve. Motor, generally we are trying to avoid it because we want relief in the pain with minimum or no side effects. That is why whenever we are doing an ablative procedure, we are more than happy to go ahead and block a sensory nerve. We do burn the mixed nerves also, but there it is a word of caution that you have to be careful while doing it, explaining to the patient, and wherever possible, try to avoid it because it will have long-term implications of motor weakness, and which is somewhere what goes against when we talk about radiofrequency in a lot of conditions that we are using it. So sensory is for positive, motor, that should not be there. So how do we do sensory? So sensory is 50 hertz. We should get a stimulation at 0.4 to 0.6. This is what the literature says. But I would be happy if I'm getting a stimulation of paresthesia in the area of distribution of that nerve at around 0.2. That is my sweet spot. I might compromise till 0.25, but 0.3, somewhere I'm not happy. I try to keep that sweet spot at around 0.2. That is one. Secondly, too near can also be detrimental. Therefore, if I start getting a lesion or start getting a paresthesia, at 0.05 volts, then I can be sure that I am very close, or in fact, I can be intraneural. Now, this is something that you need to understand. We are damaging the functionality of the nerve, not causing a physical damage to the nerve. Therefore, we do not intend to do an intraneural placement and damage it. Therefore, if you are getting it very near, so less than say 0.1, 0.8, then probably you need to adjust the needle. Fine adjustment is good enough. Motor stimulation, we get it at 2 hertz, 1 volt. What we are looking for, as I told you, are the muscular contractions of the muscles being supplied by the same nerve. Now, this we have discussed. We are discussing the standard radio frequency. When I talk about standard, what we are getting is a candle-shaped lesion. Therefore, the active tip has to be in close proximity as well as in the direction of the nerve. So, this is definitely not the right spot. So just few tips before I move on to the indications. So that is one thing which is often confused, what to use when. First, when you require precision to the point that where millimeter and centimeter counts, you need to create a lesion of ablation either where you can predict, where you are in under control, that is either by radiofrequency or something like cryoablation. When you need to cover a larger area, something like a celiac plexus. Though literature might talk about it, but on a practical front, where I need to cover a larger area, I will always go for chemical because I really want the spread. Sometimes you have to take a compromise also, but wherever possible, where you want a predictability, chances of damaging the structures are more, try to go for specific, like RFA and cryo. Spread can be then chemical. When you want to create a large lesion, spot is same, but you want to create a large lesion, then COLIF or the cool tip RF is the choice. Now RFA in spine. Now there are a lot of, I have kept the SI joint denervation out because of the time, but I will be going briefly trying to touch upon it. And if any doubts, we can always discuss. So first one is the facet joint denervation. Now before I do that, a quick recap of the fluoroscopy. So this is our famous Scotty dog. Now once you have the Scotty dog, this is the ear of the Scotty dog. Now this is the eye of the Scotty dog. Now eye of the Scotty dog corresponds to the median nerve. This is the point where you will like to place the needle, right? Only difference which I would like to make you understand is that this spot is a good enough target when you are doing a diagnostic block. So you place a needle at this spot and that is good enough. And give minimal amount of local anesthetic, not more than 1 or 2 ml. But when I am planning to do a ablation, now this is the the facet and the transverse process. So there, when you're trying to do it, you need to place the needle right at this angle, right? And because of the direction, you have to make sure that rather than going end on, you will have to go from below and place it here. Whereas when I talk about the diagnostic, you just need to put the needle here and give local anesthetic. Again, the Scotty dog, the site of the median branch, facet. Now this is the spot for a transforaminal when we are doing a DRG stimulation. Now dorsal root ganglion is present at the 6 o'clock position with respect to the pedicle. So that is the position where we need to get the tip of the needle. This is the position for doing any intradiscal procedure. So when we are doing disc denervation or when we are trying to do an RF of inside the disc, this is how we enter inside the disc and go ahead with the procedure. Now, let's, for any ablative procedure, the anatomy has to be clear. So I would just like everybody to just concentrate on this. Quite a confusion. So if you talk about this facet, you can appreciate, and if you track down this nerve, so this nerve is being this nerve is supplying the facet, and this nerve also is supplying the facet. Therefore, for facet denervation, we need to block the nerve at one level and one level above. Just this is a larger image. So when you talk about this facet joint, you follow this nerve, median branch coming down and supplying the facet. From here also, you can appreciate there is an ascending branch will again supply the facet. Therefore, if I need to denervate this joint, you need to block at this level and at this level. This is the direction of your needle. You can appreciate the articular process and the transverse process. So you have to be at that angle. So when you are putting in that needle, you will feel as if you are entering a gutter. Whereas when I do a diagnostic block, I would like to be at this spot. So my end on, it will be an end on view where I'm just hitting the body. Now this is the position of the active tip. Now this is the active tip, this is the nerve which for denervation in the AP and the lateral view. This is again the lateral view, which will appreciate that you are in that area which is formed by the transverse process and the superior articular process. Now, these are my images, and you can appreciate that in this, I had to try to make it more in contact because I was not happy with it. So I just tried to do it a slight manipulation to increase the contact area. So as I told you, diagnostic is like a small spot right at the eye of the Scotty dog. Now, this I have already talked that needle positioning is different when we are doing a diagnostic block as well as when we are doing an RFA. When you are trying to approach an RFA, do not try to go for an end-on view. Start from one level below and try to go up. That is how you will make sure that you will enter this gutter and place the needle right in the direction of the nerve. One more thing I have seen, then when you are giving a diagnostic block, people tend to overuse of local anesthesia. Try to restrict your block, the volume of local anesthetic to 1 or 2 ml. Because if you go beyond, there are chances that you might have a false positive or a false negative, because there are chances it might go into the facet and all those things. So be honest to the intervention and be ready to fail. And if the patient is not convinced, you can consider going for this block again. Now, moving on to the second thing, which is the DRG or the dorsal root ganglion stimulation. Now here, what we had discussed so far was a standard radio frequency, where what we were trying to do is we were trying to ablate the nerve which was supplying the troubled area. There is another modality of radio frequency which is called as the pulse radio frequency. What is the mechanism of action? We are still not clear. But what is the temperature that we try to reach is 42 degrees Celsius. Now, what does this do is it does not damage the nerve, but they say it has got more neuromodulatory effect. Therefore, where we are trying to do a neuromodulatory effect, that is the time when we would like to go for a pulse radio frequency. In a patient where the patient underwent a transforaminal block, patient had relief, but either the patient had a short-term relief. So the first intervention acts as a diagnostic tool where you gave a block, patient had relief, but it was a partial relief, or the patient is a case of failed back or there are multiple issues associated with it. In that case, along with along with the root block, you can also do a DRG stimulation of the pulse radio frequency stimulation of the dorsal root ganglion. Now, why is dorsal root ganglion so important? Because as we all know, dorsal root ganglion is like a big signal where all the impulses, good, bad, are where they are traveling, and most of them, the pain signals, are the ones which are being carried. So that is the site of impact also when you are trying to do any sort of a disc prolapse or condition is happening. So this is exactly the position of the DRG. How do we see it in fluoroscopy? This is at the 6 o'clock position with regards to the pedicle. So people who have interacted with me would remember that when doing a transforaminal, I'm not so particular about because I always feel if you are inside the foramina and you get a good dye spread, it hardly matters whether you got a perfect Scotty dog or you didn't get a perfect Scotty dog. But when you are doing a radio frequency ablation, when you are doing a DRG stimulation of a root, precision is the key. There are no two ways about it. So if you have planned it, the needle tip has to be at the 6 o'clock position, even if you have to take some time, but it has to be at the 6 o'clock position when it causes to. Moving on to the last topic, which is the disc denervation. Now we all realize that whenever we have a discogenic pain, now discogenic pain can be relieved by two things. So now that discogenic pain can be either because of herniation of the disc or where the patient has gone some sort of a degeneration. Now debulking of the disc is something, or decompression is something which we won't be discussing because that is something different. But what we will be talking about is in patients of long-standing back pain or in patients of DDD, degenerative disc disease, what happens is that there is some sort of an annular tear because of which there are neovascularization which has taken place. Then when those new nerves and blood vessels have taken place, have grown there, they are the ones which are responsible for pain. So what they say is that we can use this radio frequency as a technology and ablate all those nerves. So my dear friends, when we are doing a discal procedure for decompression, our target generally is the central part or the nucleus pulposus part of the disc. But when we are trying to do a denervation of a disc, we have to be at the posterior annulus, because that is where the problem is taking place. So now this is what I was trying to, there is blood vessels which are coming, and mostly are coming from the outside to the inside. Therefore, whenever we are trying to put a needle placement or the electrode placement, it has to be in the posterior part of the disc. Now, these are the various techniques where we have put it inside 45 degrees. There we have put it in the kind of a loop. This is IDET. Then again, this is where this is a technology where we are putting it in the posterior annulus. And this is the one which is we are using more frequently nowadays, which is an intradiscal bicoloplasty, in which we put 2 electrodes right into the posterior annulus, complete the circuit, and bring about the lesion. Especially with cool tip RFs, this has become quite easy to do it. But what has happened is these things, when it comes down to using RFs in discs, because the evidence is not so great, plus at the same time, cost becomes equivalent to a surgery. Third, the surgery has also advanced, specifically with endoscopy. The indications are reducing. So if we talk about review of literature, the thing which has got the highest level of what we call its evidence is definitely the median branch block. First and foremost is patient having back pain, which is suggestive of coming from the facet, are grossly underreported in the MRIs. Therefore, do not hesitate to do a diagnostic block where history is suggestive of a facet joint arthropathy. There is enough ample evidence for using it in your day-to-day practice. As I told you, for intradiscal, this was in 2020, where they said that yes, there is evidence, but it is not conclusively good quality evidence for us to promote its use. So carry home message would be precision is the key. You have to be precise with the anatomy, with your training and everything. Never the first injection. No matter how confident you are, never the first injection. In fact, I would go on to extend that if you, and especially if your patient is not convinced with the first diagnostic injection, do not hesitate to inject again, because patient satisfaction is extremely important when you are doing this. Right intervention, if done by the right hands, can never fail. Thank you so much. Any questions?
Okay, sorry. Dr. Kiran, you are on mute. I will unmute you.
I am sorry, I assume that the doctors are there. Well, they are familiar with it. So
Hello.
Any doubts, any questions, sir?
Yeah. So, Doctor, excellent presentation. I think you have covered, starting from the basic, and even very wonderfully explained the most commonly used 3 indications which we use for radio frequency. There is one question which, because of limited time, we'll take only 1 or 2 questions. There is a question which is asked is, do you do diagnostic block and RFA at the same sitting? And can you explain how, or if there is a gap, then what is the gap in between them?
Very good question, sir. Diagnostic and the RF, never in one sitting. I do the procedure, ask the patient to go back home. He has my number, he has my team's number. So till the time he is convinced, I never push them. Because 2 reasons. Firstly, what I am assessing is, firstly is the pain relief. I take it as 50%. If there is 50% or more, then I would be one which I will be going ahead. That is point 1. Second thing is, sometimes the patient is not able to appreciate. So what I ask the patient is, go back home, let your pre-existing pain come back. So that also acts as a measure that once the local anesthetic weared off, how bad was the pain. And then I ask the patient to take up a call. I never try to rush to do it in the both in the single sitting.
Excellent. So there is one more question which I'll be asking for clarification to everyone. Since there are only 2 questions we'll be taking, can you elaborate, because it is one of the very important part, but very least spoken and least bothered, especially if you are starting to do RFA techniques, is about the application of the pad, which is basically grounding pad, which is applied to the patient. So can you elaborate a little bit about where it should be and what is the importance of it?
Sir, firstly, the thing is, it is extremely important because of 2 reasons. Firstly, the circuit has to be complete for effective RF lesioning. So therefore, it has to be well contacted with the body. Second thing is the contact again has to be proper. Otherwise, there are chances of burns. In a normal patient, what I generally do is I put it in one of his legs with proper gel applications and make sure that it is tied up properly, because in our resource poor country, we are using it for repeated things. So what I generally do is, it's a small trick that we do once we have fixed it with proper jelly and everything, we make sure to bandage it as well, so that we are sure that it doesn't move. Then that would be
right. So just to take that discussion forward, and then we'll move on to the next speaker. The pad application is very important because, as Dr. Dhruva explained, that the mechanism of RF is not because the needle tip gets heated. It is important to understand that when the circuit of electricity is completed through the pad and through the needle, the surrounding tissue gets heated. And if your pad is not applied properly, try and apply it as much near to the needle or the area of work as much possible, rather than applying to a very far area. Secondly, make sure that it is applied in the opposite direction to the needle. And at the same time, it is applied very snugly, because I have myself experienced at times, because of wrong application, at times you are in a hurry and your assistant does that, there can be a burns at the site of the pain. Patient experiences that, he tells that I am getting burned, and we feel that it may be because of the RF stimulation. So pad application is one of the very important areas which we should be conversant with. So thank you, Dr. Dhruva. I think there will be a few more questions, but I'm sure we'll find another forum and a place where we can discuss those. So now moving on to the next talk, and I would like to invite Dr. Uttam Sidhaye, leading pain physician in Pune, to give a talk on cooled radio frequency ablation indications.
Dr. Kiran, it's Dr. Das now.
Oh, I'm sorry. So sorry, because there is a change in sequence. Dr. Gautam Das will be speaking first on cryoablation, when and where. I am sure there is no need for me to actually introduce Dr. Gautam Das. Is a leading figure in pain management in not only in India but all over the world. Is the medical director of Daradia Pain Clinic and has trained thousands of pain physicians all over the world. Is invited faculty at many national and international conferences and received numerous awards. More than 100 research papers are on his name. And we always look forward to meet him, discuss with him difficult cases, and understand basics as well as the advanced techniques from him. So looking forward to hear you, Dr. Gautam Das. I hand over to you.
Yes, thank you, Dr. Kiran, and seeing you again after a long time.
Yes, sir. Thank you.
So, can you make me co-host, Dr. Barsa?
Yes, sir. Yeah, you are the co-host now. You can start sharing the screen, sir. Yeah, your screen is visible. Perfect.
Okay, so what I'll do, I'll be just trying to focus on the basics, very basics about the cryoneurolysis and what are the advantages and disadvantages, principle, how it works, comparison with the radio frequency, and then just a little bit of applications, what to be done. So neurolysis is, ablation. These are the different ways. In this topic here, unfortunately, chemical neurolysis was not kept. That is another thing. So this slide is very important. That when we are doing the neurolysis, so sometimes there is a possibility of the deafferentation pain. And I'll be coming in the detail about the deafferentation pain, because unless we know what is deafferentation pain, it will be, the difficult. So this part I'll be talking a little bit more details in subsequent slide. First, let us know that the regeneration's nerve has, the basic physiology. Nerve has two parts. One is cell body, and another is your dendrites and the axons. So the functions of the dendrites and axons are what? Just the propagation of the signals. All the metabolic actions are taken place in the nerve cell. So if we are ablating a nerve cell, nerve will never regenerate. But if you are ablating the dendrites or actions, the nerve might be regenerated depending on what degree of nerve damage it is. So to understand the neurolysis, this is the very basic thing what we need to understand. And before that, let us see the nerve, the little bit of anatomy, very fundamental anatomy, and what are the different degrees of lesion, what we can produce with the different mechanisms. So first of all, each nerve bundle is made up of an individual nerve filament. And individual nerve filament, as you know, that it has an action and it has a covering, which is known as endoneurium. So each neural filament have a neural filament, an endoneurium. And that is very important, endoneurium. Why? Endoneurium is equivalent to the cell membrane of any cell. And as you know, cell membrane is having the two layers, two lipid layer and one protein layer in between. And it is because of the two lipid layer, it is it cannot allow the water to pass except, or any charged ion to pass, except certain areas where there is a specialized protein, means in between protein layer is peeping above and below and making a hole through which the ions and the waters can go in or out. So that is very important. So in the axons and dendrites, one of the very important protein or ion channel is their sodium channel. So through this sodium channel, basically the axon potentials propagate, and we all using the sodium channel blocker, local anesthetic, which can block the axon potential propagations. So these sodium channels, they are, why they'll be manufacturing like any other protein in our body. Our proteins are naturally, it is getting, by the proteolytic enzyme, it is broken down into the amino acids. This happens. Every proteins are recycled. No protein in our single protein in our body once formed in your fetal life last for whole life. Never happens. Active cell means it is always manufacturing the proteins. There is a proteolytic enzymes with which it is broken down and again it is synthesized. So same thing is applicable for every cell membrane, including a nerve cell. So these proteins, including these ion channels, they are being manufactured within the nerve cell. And then they are propagated peripherally. How? Through this endoneurium. That is why I was telling you, to understand the neurolysis, you must understand the endoneurium very nicely. So through this endoneurium, means the cell membrane of individual nerve filament, axons and dendrites, these proteins are once manufactured within the nerve cell body, then they are going peripherally. So now if you are doing a damage, if you are ablating the nerve, so what can happen? At that damaged area, where the endoneurium is damaged, these sodium channels will be getting accumulated because they cannot go further distal. And these abnormal high density of the sodium channel proteins can be a source of your ectopic signal generation. So that means when we are doing a neurolysis, damaging the endoneurium, we can make the pain worse. So this we have to understand. That ablation of the nerves, axons and dendrites is not everything. Many times we can make the pain worse. Like suppose surgically you are ablating a nerve. Suppose somebody is having neuropathic pain. Shall I ask them, say for example, the hernia, herniorrhaphy, ilioinguinal, iliohypogastric nerve entrapment. Earlier, these papers was there that, the surgeons identified these nerves and ablated the nerves. But pain never, recovered. Pain never relieved. Pain was there again. So it's like phantom limb pain. The nerve is ablated, But because of this abnormal sodium channel accumulation at that damaged area, the pain may become worse in a good number of patients. So here, so keeping this in mind, that means endoneurium is the key. Endoneurium intactness is key to prevent this worsening of the pain after a neurolysis. So now coming back to this slide. So these are the different degrees of the, the neurolysis. First degree nerve block is also called a neuropraxia. So what is first degree nerve block? There is, with the electron microscope or with any microscope, you cannot see any structural damage. Only there is functional loss, means the action potentials are not being propagated. So this is called neuropraxia. So here the conduction loss will be there for how long? For 30 minutes up to maximum 7 days. So this is known as neuropraxia. It can happen if you are pressing a nerve, if you're applying the cold over the nerves, so then the neuropraxia can happen. So neuropraxia can be therapeutically utilized by application of the cold. So, this question is very frequently asked. What is the mechanism of the pain relief if you are applying the cold? So one mechanism is very important, is this neuropraxia. But another mechanism is there, that there is a reverse vasodilatation. So that might be also helpful. But this is very important, that when you are applying the cold there, even if it is not damaging the nerve, even then you might be getting the pain relief because of this neuropraxia. Now it comes second degree. Second degree is also called the axonotmosis. So what happens here? Here the actions are lost, but the dendrites, the endoneurium. So endoneurium, and then what is there? The perineurium. So individual nerve filaments together bounded by one, the sheath that is known as the perineurium, and then the different bundles together is your epineurium. So the three coverings are very important. Endoneurium, that is the basic, what is most important. Second one is perineurium, and third one is your epineurium. So second degree means all these three. Please. Barsa, can you mute? Somebody is background talking.
Okay.
Yes.
Okay, so second degree, if we are doing, then that means the axonotmosis. Here all the three layers are intact. And here, when the regeneration will be there, regeneration will be perfect. And there will be no chance of any deafferences and pain, no chance of worsening of the pain. And here, what happens? The recovery. Dr. Barsa, please, somebody go on talking. So,
Dr. Chetan, can you go on mute? I'm not able to find you. Just a minute.
So the second degree nerve block, then third, fourth, and fifth degree is called neuronotmosis. So neuroatmosis, what is neuroatmosis? So there is the endoneurium, perineurium, or epineurium. If the endoneurium is lost, only endoneurium, but perineurium and epineurium is intact, then there is a high chance of full recovery of the nerve with a possibility of, because endoneurium is damaged, so there is a chance of ectopic signal generation, there is a chance of crosstalk. So this possibility is there. And this possibility is minor, but it is there. But third degree means always there will be regeneration. Fourth degree means it is, the perineurium is lost. So not only the endoneurium, it is perineurium is also lost. So here the chances of recovery is less chance of regeneration, but still regeneration will be there. And when there will be regeneration, there is a very high chance that this, will be associated with the sequelae. The pain worsening possibility is much more. And when the epineurium is also lost, so the nerve is losing the continuity, and some soft tissue is coming in between, the nerve will never regenerate. So this is your fifth degree. So keeping this in our mind, so first I'll be looking that how application of the cold can do the different degrees of neurolysis, and also how different degrees of the heat is also going. That is basically the radio frequency. So first, what I told you, that if we are applying the cold, so we are producing the neuropraxia, and that neuropraxia can be achieved with the 10 degrees centigrade plus 10 degree to minus 20 degree. And then the neuropraxia means first degree without any damage, and the patient might have the pain relief for sometimes between the half an hour to few days. Second degree or axonotmosis. So this can be achieved to a temperature somewhere between the -20 to -100 degree. And this is our target in the cryoneurolysis. So if we are achieving this one, so what will happen? The pain relief will be there somewhere between the 2 months to 2 years. And there'll be absolutely no sequelae. Then 3rd degree and 4th degree, with the application of the cold, with the cryo, we need to go below 140 degree. Then we will be getting the 3rd degree or even 4th degree sometimes. But what about the radio frequency? Radio frequency also causes the 3rd degree and 4th degree lesion. So now, why radio frequency? What is our aim? And again, it is temperature dependent. That means if our temperature is somewhere around 80, the 65 to 80, normally we are achieving a 3rd degree lesion. 2nd degree lesion is not possible with radio frequency. So radio frequency is always going to produce 3rd degree lesion, and this 3rd degree lesion is going to achieve between a temperature of 65 to 80. If you are going more than 80 or even more than 90, basically the charring of the tissues, but more than charring, what is important is that we are going to create 4th degree lesion. So if there is a 4th degree lesion, what is the benefits and what is the disadvantage? As I told you, 4th degree lesion means there is less chance of recovery. That means we might be getting the long-term pain relief, but at the cost of what? At the cost of more chance of deafferences and pain. So the chances of deafferences and pain will be increasing if we are going beyond 90 degree. And that is the reason why in the radio frequency, we try to get below 90 degree, preferably around 80 degree, not going above 80 degree, because chances of deafferences and pain will be increasing. From 3rd degree, we are going to the 4th degree lesion, and that is not beneficial. And 5th degree, so normally, 5th degree is not possible with the radio frequency or the cryo or these things. 5th degree is mostly by surgical ablation. Nowadays, that is also another technique to do the radio frequency, particularly in the sacroiliac and the fascial joint under the direct vision of the endoscopy. So the 5th degree lesion, but again, what I told you earlier also, that the 5th degree lesion have the most important disadvantage, and that it might be worsening the pain in certain situations. So keeping this in our mind, so what is the cryoneurolysis definition? So cryoneurolysis, cryoablation, cryoanalgesia. So these are almost similar terms, but or literature-wise might be meaning the same. But we prefer more in certain conditions. Like cryoanalgesia is normally we restrict the term when we are applying cold. We are aiming at the 1st degree nerve block. Then we call it as a cryoanalgesia. The temperature should be something around, below 10 degree, plus 10 degree. Cryoablation, again, we can call it as a cryoablation of the nerve. What is cryoneurolysis is basically cryoablation of the nerve. But mostly the cryoablation term is restricted to the tumor ablation. But if you told that the cryoablation of the nerve, literature-wise, you are not wrong. You are correct. But again, mostly default setting of this meaning of the cryoablation is basically for the tumor ablation. And cryoneurolysis is the specific term. So here we are, ablating the finer branches or even sometimes the larger branches by the cryo. And this is the history. Cryo is not new. So what is new is the finer needles. Earlier, not needle, I should say, cryo probes. That is new. But as a whole, cryo application of the cold is not new. So what's the physics behind it? Means when you are putting the cryo probe there, so how I told you it is not needle, because tip is not open. You cannot inject anything through the cryo. That means when you are doing the RF, what you are doing? Before doing the RF, you are giving local anesthetic, and then you are doing the heat lesion. But in the cryo, you cannot do that. Why? Because the principle is, so there are 2 channels. The outer channel is constricted. Suddenly it gets open at the tip, and then through the larger inner channel, the gas is coming back. So because under the compression, this constriction, suddenly it is getting released. So there will be, the Joule-Thomson effect, by which, this is the basic principle of any of these, the refrigerator, the air conditions. So everywhere the cooling mechanism is same. That means the gas is passed under the pressure, and suddenly the pressure is released so that the temperature will fall. How much temperature will fall? It depends on the freezing point. So carbon dioxide freezing point is your minus 79 degree. So normally it will be below minus 79 degree. That means if we are using carbon dioxide, so normally we get a temperature of minus 78 degrees centigrade, because 79 degrees is the freezing point. That it will not reach that part, because it will be remaining the gaseous. The nitrous oxide, so you can achieve the temperature of minus 80 degrees centigrade, 87 degrees centigrade. So these are the two gases what you can use it for the second degree deletion. As I told you, our aim is to do the second degree deletion. Second degree deletion can be achieved where? By minus 20 to minus 100. If you are closing to the minus 100, then what will happen? Then the regeneration of the fibers will be late. Particularly what has been seen, that if you are doing a cryo, even for a mixed nerve, suppose something, the intercostal nerve or some other nerve, so there is a motor fiber, so there is a sensory fiber, touch fibers or pain fibers. So normally what has seen that the larger diameter fiber, touch fiber and the motor fibers, they recover within few weeks, maximum up to 2 months. But the pain fibers, they take longer time to recover. So it may take 2 years, In our setup, we are frequently doing cryo, and most of the times the pain relief is somewhere around 1.5 years, and in some situations even more than 2 years in certain situations, and that can be achieved by the second degree deletion. So the size of the lesion, as I told you, the beauty of the cryo in the recent cryo probes. Cryo is not old, as I told you, but in the recent, last, the 5 years maybe, it has been, a lot, as searching that in the US also, many of these, the pain, most of the recent research article topics is almost everything, lot of papers with the cryo. Cryo is really had the several advantages. I will be coming to that later on. But what is new in the cryo probe? Because cryoablation is not a new. Tumor ablation of the cryo is done for the several decades. But new is the engineering mechanism by which, even with a 22 gauge needle, not needle again, I'm doing the mistake, 22 gauge probe. So there is an inner and the outer tube through which the gas is passed. So this is new. That means very fine cryo probe has been developed, which can give you the flexibility of doing a very small size lesion of 4 millimeter to up to 80 millimeter. So if you're taking a longer cryo probe, if you're taking a larger gauge cryo probe, so you can have a larger size lesion, or you can have a smaller size cryo lesions, depending on your choice. So see, this is a 22 gauge. So the tip is very small. It can be used in a very small nerve, like the Baxter neuroma. The Baxter neuropathy or many others, very small nerves, you can use this on. And at the same time, you can have the very large cryo probe. You see, this is the ice ball. So here the ice ball is very small. The length is approximately 8 millimeter. Width is approximately, the 3-4 millimeter. Whereas if you see this one, here the length of the lesion is, more than the 80 millimeter. So we have having the flexibility that by using the cryo probe, not the machine setting. Machine setting is different. So if you wish to have a larger size lesion, you have to use a different probe, not the same probe. And here, another important thing is compared to the radio frequency, the machine can set the temperature that, okay, I want to have the lesion at 70 degree or 75 degree or 80 degree. Here, you don't have the flexibility. If you wish to change the temperature, what you have to do? You have to change the gas. Like as I told you, the most too frequently used gas is your carbon dioxide, which can reach your temperature minus 78 degree, or you can use the nitric oxide minus 87 degree. But the difference between these two is almost negligible. Why? Because as I told you, our aim is to produce a second degree lesion, and the second degree lesion you can achieve somewhere between the close to minus 100 degree. So with both the gases, we are going to get the almost similar effect. In our hospital, we mostly use the carbon dioxide gas for this the cryoneurolysis procedure. So this is the machine. And this is the carbon dioxide cylinder, which is attached in the back. And then through this, the gas will be coming. These are the different, the cryo probes. So there is also like radio frequency. Here also you can stimulate the nerve. So with this, there is a ground pad, you competing the circuits. And if you can see this, there is also insulation. You see, there is also insulation. So why this insulation? Up to this is your the insulated part, this is your active part. Why this insulation? Because cryo don't need insulation. So this insulation is to stimulate it. So you can do the same sensory stimulation, motor stimulation to be sure that you are close to your nerve, and then you are going to ablate it. So the mechanism is freezing and defrosting, so that the vasonervorum, they are getting freezed, and that is why you are doing the lesions. So now what are the advantage? And also I'll be coming to the disadvantage as well. The most important thing is direct visualizing the ablative zone with the USG. So this is very important, that with the radio frequency, we can't see anything, neither with the ultrasound nor with the radio with the CM. We can't see, we can see the needle. But you can't see where we are basically ablating. But when you are doing the cryo, basically cryo and the USG is basically, go hands in hand. When you are doing cryo, mostly you should use the ultrasound, because we can see the nerve, or you can see even sometimes we cannot see the nerve, like the genicular nerve. We cannot see the nerve most of the times. Very rarely you can see the nerve, but you can see the pulsating vessel. So you can put it near your vessel. And you can see the ice ball is forming, and you can be sure that, okay, my success is certain. So same thing, name any other, the peripheral nerves which is accompanying with the blood vessels, like, the mental, infraorbital, supraorbital. Most of these videos also are there in our YouTube channel. You can go through and you can see how we are doing the cryoneurolysis. So the advantage is the application of the USG and visualizing it directly so that your success is certain. Decreased procedural and post-procedural, no procedural pain. Why? Because as I told you, we cannot inject local anesthetic and don't need it, because the procedural process of the cryoneurolysis is painless. Immediately on the table, patient will be really having the pain relief. Like, unlike that of the radiofrequency, where the radiofrequency procedure will be giving you the pain relief only after 2-3 weeks. No, maximum sometimes 1 week, but it is not immediate. Radiofrequency pain relief takes some time, but here immediate on the table. Because of the cryo itself, not because of the local anesthetic effect. Because this is another disadvantage of the radio frequency. But sometimes what happens, we are giving local anesthetic. Local anesthetic will be spreading to the surrounding tissues. And you might be having sometimes the false positive results, both in the diagnostic block as well as during the procedure. So on the table, you might be feeling that, okay, good pain relief and we are happy. But it may not be so, because the local anesthetic can trickle down in the different areas, but your lesion is not going to trickle down here and there. So here, if you are having on the table pain relief, that means you are very much sure that you are on the target, because no procedural pain and the post-procedural pain. You can simultaneously do the multiple probes of the various configurations, the smaller size, the larger size. The flexibility is there. And the very important part is that not associated with the deafferences in pain, because it is doing the second degree lesion. There is no chance of the worsening of the pain. It's never happened with the cryoneurolysis. Pain relief is for around 6 months to 24 months. As I told you, most of the patients get the pain relief of around 1.5 years. That is the minimum level of the pain relief. Contraindications, infections, bleeding disorders, cryoglobulinemia, that is a very rare things. Cold urticaria, these are the contraindications. Side effects. Now I'll be telling you, before coming to this, the disadvantages. What are the disadvantages and where you should do? Now my topic was where to do and where not to do. So the most important part of cryo application is where we are targeting the mixed nerve. Say for example, intercostal nerve. And I always give this example, one of my complication in my patient, that the patient was having the intercostal neuralgia. And we did the diagnostic block. Patient was having fantastic pain relief. And then we did the pulse radiofrequency, because pulse radiofrequency is recommended. But unfortunate part is pulse radiofrequency have a very high failure rate. In my patient also, there was a failure. Then the patient came back again to me. And then I thought, okay, because the heat lesion should not be done in the intercostal nerve, because the same intercostal nerve is going to supply the anterior abdominal muscles. So then I lowered the temperature and I did it at 65 degrees. But again, that pain relief was very transient. So third time I did it. And then I did it at 75 degrees. But what happened? Because the patient was having, the desperate pain relief, medications are not helpful, side effects of medications. So the patient had pain relief, but patient developed a hernia because of the weakness of the anterior abdominal muscle. So this is one of the side effects which, I learned from my mistake, from this complication, that the heat lesion should not be done. Even in the desperate situation, your hands are tied up. You cannot do anything in these patients. But the cryo is the solution. With the cryo, what you can do, that mixed nerve, say for example, the intercostal nerve, Say, for example, the greater occipital nerve, where there is a important cutaneous sensations, then your genitofemoral nerve, then your ilioinguinal nerve, then your the lateral cutaneous nerve. In all those situations, mostly the pulse radio frequencies, if you're at all going to do the radio frequency, it is pulse radio frequency. But again, pulse radio frequency has a very high failure rate. So in all those situations, you can do the cryoneurolysis because there will be no long-term sensory loss or motor loss. So the most important application is peripheral nerve, where the sensory supply, motor supply is there, and you are not going to do any motor loss. Transient motor loss might be there only for 1 or 2 weeks, but there will be no permanent motor loss, there will be no permanent sensory loss. So this is the advantage. If you wish to ablate a mixed nerve, like say, for example, I can give you another very important example, that in medial knee pain, in desperate situations, there are lots of radiofrequency failures in the, those who are doing the genicular nerve RF, they know the failure rate is not, it's, even if after doing the cooled RF, conventional RF, the failure rate is there, failure is not uncommon. So in those situations, one of the very important option is you can go, particularly for the medial, the knee pain, you can go to the adductor canal block. You can go into the subsartorial plexus. You can do a little bit of hydrodissections. You can, when the nerves will be under the ultrasound, you can see that the nerve is well dissected out, the nerve to the vastus medialis and the nerve to the saphenous nerve, and you can do the cryo. So advantage is that you are not doing any sensory loss. You are not doing any motor loss. Nerve to the vastus medialis will be absolutely normal, and you will be attaining the very good pain relief. So this is the advantage, that where there is a mixed nerve, you wish to ablate that, you can easily go ahead, because the side effects are of the motor loss, side effects of the sensory loss is not there, because everything will be recovered very, very quickly. This is the most important, application of that. Apart from that, another very important thing is where you wish to create a large size lesion. As I have shown you, that you can create up to 8 centimeter lesion, like in the sacroiliac joint. So, we had the world's first publication about the cryoneurolysis of the sacroiliac joint. And subsequently, another publication is basically, we have submitted long-term with a cryoneurolysis. So the cryoneurolysis of the sacroiliac joint, where you are having a large size lesion, that means when you are having a large size lesion, like in my earlier lecture, the Dhruva was a very nice lecture, and there he mentioned it is a sniper. I call it targeted missile. You are just targeting and ablating the particular nerves. But many a times what happens, if the nerves are very small, targeting a particular nerve is difficult. Like the SI joint, lots of lateral branches are coming. So there is another technique. What is that? Carpet bombing. You bombard the area, and all the small areas will be ablated. So, but you have to be very sure that the collateral damage of the carpet bombing is very negligible and not there. So here, like in the SI joint, so if you are going along the medial border of the sacroiliac joint, there is no important motor fibers. There is no important touch fibers. So you can well ablate in that area with the carpet bombing, long lesion along the medial border, and you can have the, very good, excellent results with this. So the cryoablation is where you want to have a large size lesion. One of the very important areas is we will do that. Another important area is that where there is a, the recurrence, repeated recurrence, like in the Castellan ganglion or some other areas, you have done the ablated it. It was very, very good. But again, there is a recurrence. Repeated radiofrequency can, the more chance of worsening the pain if you're doing again and again the heat ablation. So in those situations, instead of repeating 2-3 times, more than 2-3 times radiofrequency, another option is to go for the cryo. Cryo, any number of repetitions, not going to worsening the pain because the regeneration will be absolutely perfect. So these are the advantage, disadvantage, but most important, all I told you is the advantage. But the disadvantage, the most important disadvantage is that the duration of pain relief is slightly shorter than the radiofrequency. Radiofrequency, as I told you, it is 3rd degree lesion, but here it is to 2nd degree lesion. That means if you're comparing with the radiofrequency lesion, as I told you here, the radiofrequency, like Castellan ganglion and many other situations, the pain relief can go, more than 4 years also. But here, more than 2 years pain relief is very rare. Most of the times, as I told you, 1.5 years pain relief. This is one of the important disadvantage, that the duration of pain relief is shorter compared to that of the radiofrequency. So this is on. So here this was the artery, this is the nerve, the ilioinguinal nerve. and we are doing a genetic femoral nerve ablation. This is the lesion. You can see this is the ice ball formed, and it causes the acoustic shadow. And we are sure that, okay, where we are we close to the nerve or not? So this is another genetic femoral nerve. This is a scar neuralgia. Scar neuralgia is also very, very nagging kind of pain. Everything fails there. So just below the scar, you can put a long, this radiofrequency, sorry, not radiofrequency, the cryo probe, and you can do the lesion there. So these are the long list, starting from the gastrin ganglion. I told you in the gastrin ganglion, if it is a recurrent gastrin ganglion, 2-3 times already have ablated, you can go ahead. The occipital nerve, where pulse radiofrequency can be done, but again, I told you the pulse frequency has a very high failure rate. Medial nerve for the facet joint, again, the repeated cases, you can go for that. The suprascapular nerve, if you're doing on the suprascapular notch, you cannot do a thermal ablation, because nerve to the supraspinatus, nerve to the infraspinatus are there, and it will be making that muscles weak. But you can do the cryo, because it is not going to do the motor loss. Intercostal nerve, ilioinguinal, iliohypogastric, genetic femoral nerve, scar neuralgia, SI joint, cranial nerve, genicular nerve for the knee joint, the medial calcaneal nerve, phantom limb pain, pudendal nerve. So there is a long list. But again, the most important area to choose the patient where is your peripheral nerves, the mixed peripheral nerve, where there is a sensory fibers, where there is a motor fibers, where you can't do the radio frequency, you can't do the cryo. So thank you very much. Any questions?
Thank you, sir, for a very lucid and elaborate presentation on cryoablation. One question that I would like to ask. You said that, of course, for any ablation, we need to confirm it, especially if you are doing under C-arm. I mean, under sonography, probably you are very sure where you are. As a stimulation. So this stimulation that you said is done again, the same probe is used, but then which current you use at that time?
Yes, it's exactly same. As I told you, this probe has the insulated part and the non-insulated part. So the non-insulated part works like an electrode. So what you have to do is same the 50 Hz current for the sensory stimulation and 2 Hz current for the motor stimulations, to be sure that you are close to the sensory fibers and away from the motor fibers. And then you can go ahead with that. Because very small fibers, very small, the nerves, you may not be, and which is not accompanying by the blood vessels. So even with the ultrasound, you may not be able. The classical example is the medial branch for the facet joints. Sometimes you can see the accompanying blood vessels, but in 50% situation, we can't see it even with the ultrasound. So there, we are relying on the, on the position that we are at the junction of the superior retractor process and the transverse process. And here, the stimulations might be helping you. That means the two way we are becoming sure. One is either you are visualizing the nerve or the accompanying blood vessels, and second thing is stimulation.
Right. So the lesion will be only on the non-insulated part.
No. It will be, the lesions, like what I mentioned is, to be more precise, the stimulations will be smaller area, but the lesion will be little bit larger than the area of the non-insulated part. So, because as I told you here, even if you are ablating some nearby motor fibers, you stay bindas, then nothing will happen, because ultimately everything will be recovering. So that is the reason why the machine has the cryo probe they have prepared like that. To be very sure that when you are stimulating it, we are very sure that you are very close to the nerve. But actual size of the lesion will be more than your area of the non-insulated part.
Right. And once you have done a cryoablation, right, there is ice ball formation. Now you'll have to withdraw the probe as well. So we have
to wait till the thawing is completed. So you can see under the things that the thawing is completed, because both is important. And when there is the ice ball, you cannot take it out because it gets attached to the surrounded tissues. And, then you have to apply the force and everything will be seared off. So you cannot do that. So you have to, under the probe, you have to be very sure that the ice ball has melted completely, the complete thawing, and then only you can take the needle out.
Usually, how much time does it take?
Normally, the cycle is 2 to 3 minutes of freezing and 1 minute of thawing.
Oh, within 1 minute, you can withdraw. Then
yes.
That should be okay. There is one more question which has been asked, and I can read it here. Why motor fiber is not affected?
No, it is not. I never told that it is not affected. I told it will also be ablated. All the fibers will be ablated. But the larger the diameter fibers, they recovers very fast within a few weeks. Maximum up to the touch fibers takes maximum means 2 months for the recovery. But the motor fibers are immediately within a week or two, the motor fibers are recovered. And the smaller diameter fibers, smallest diameter fibers, they are recovered, regenerated up to 2 years. And in some cases, more than 2 years I have seen.
So when the blood vessels are nearby the lesion, are there any effects on the
No, because the very small diameter fibers, particularly the vasonervorum, they are getting affected. But the vessels, what we can see there, it will be dispersing the heat so much that there'll be nothing. In fact, when you use the probe there, particularly, I'll be asking those who are asking this question to go to our YouTube video where there are lots of cryo lesion, where when you are holding the artery, you can see it is pulsating. Surrounded thereby, the ice ball is formed. And then gradually the pulsation is same going on. But the ice ball is there and it is gradually ice ball is formed and gradually ice ball is melted again. So it is not going to freeze this is one of my, sometimes I thought I'll be doing, I forgot it, to have a Kahoot questions so that everybody could interact about what I have taught. So there I mentioned, is it a complication that there will be, the embolism, the cryoembolism, ice ball formed and it is embolized, distally. Is it a possibility? Is it a complication? Answer is not at all, because when there will be flowing, the circulation, ice ball will not at all form.
Sir, one practical question, as compared to the radio frequency, how cryoablation compares in terms of the budget or the cost to the patient?
If you are comparing with the cost, it comes in between the cooled RF is most costly, as you all know, because of the cost of the kit. It is less costlier than the cooled RF, but more costlier than the conventional RF, because conventional RF, the probes, needles are very economical. You can use it a few times. So altogether, the cryo probe cost means the RF needle cost comes maybe around 200-300 rupees if you are using it, 4 or 5 times. But if you are coming to the cryo probe is normally there is a fixed number of cases you can do it. More than that you cannot do. There is there will be a barcode. You have to put the cryo probe into the machine. Machine will be recognizing the barcode and machine will be telling that this much number of cycles already has been done. So mostly depending on the different types of probe. So these are meant for around 25 cycles or maybe 50. Some probes are for 50, because it is very fine. You can do only the 25 times, but little bit of larger gauge where the metal is basically thicker, there you can do it for the more number of times, maybe around 50 times. And the cost of the probe is somewhere between the 1.5 lakhs. So you divide, that means the cost is coming something around your, 5,000, 6,000, something like that. So right. it is more costly than the conventional RF, but definitely less costly than the cooled radio frequency.
Cooled RF, right. So there are actually many
one more question to the sir.
Okay. We'll take the last question.
Sir, how you put the probe for the sacroiliac joint? It's like simplicity probe.
Yes, it is exactly like the simplicity probe. We are putting it from the lower part of the SI joint, and then we gradually slides it up to the upper border, covering entire medial border, and all the lateral branches which are going, you can ablate it at a single go. It will be very time consuming, but the less time consuming as well. But unfortunate part is now, the long cryo probe, what I have shown there is for few months, it is not available in India. I was telling the dealers to bring it, but that is fantastic. A single go with 5-10 minutes, you can complete the procedure. Because otherwise in the RF, what is happening? You are putting individual probe needles. It takes a very long time for the radio frequency to complete a sacroiliac joint.
True, sir, true. So really, sir, it's always a pleasure and very interesting to hear you. Thank you very much for a wonderful presentation. There are actually many questions, but I'm sure we keep it for some other day, because we have another great speaker.
Yes, I understand. We are already very late. And from my side, thank you very much to the Pune Pain Society. Thank you, Barsha. Thank you, Barsali. Thank you, Kiran. So for this opportunity and interactive, thank you, all of you. in the organizing team. And it was a wonderful time I spent with him. I'll be there till the last lecture.
Great. Thank you, sir.
The questions are in the chat box. So in the meantime, you can answer directly.
Okay,
So,
I'm trying to answer all these questions.
Yeah, thank you, sir.
So we'll move on to the next presentation, which is basically about cooled radio frequency ablation, which is another way we do ablation for nerves. And this is now being commonly used considering the size of the nerve. And there are a lot of questions and queries which come up about cooled RF. So we have Dr. Uttam Sidhaye, a leading pain physician from Pune. He's medical director of pain management clinic and consultant at Deenanath Mangeshkar Hospital, as well as he also works with Bharati Vidyapit and doing wonderful job of teaching fellows there. He is also a very great presenter at various conferences at national and international level, and he has done special work at SI joint pain and peripheral vascular disease. So without taking much time, I invite Dr. Uttam Sidhaye to share his experience and talk about cooled radiofrequency ablation.
Thank you, Kiran. I will share my screen. First of all, just a minute. Sorry. Can you see my screen?
No, sir. Not yet. Yes.
Can you see?
Yes, sir. It's visible. If you can make it full screen.
1 minute. Can you see now?
Yes, sir.
Okay. On the behalf of SSPP, I thank Dr. Gautam Das and Dr. Dhruva for excellent presentation. This is an academic meet every month we conduct this academic meet, and you have made my work seem easy because you have explained everything, anatomy as well as the technique of the radio frequency as well as cryoablation. So I'm going to talk about the cooled radio frequency ablation, which we are routinely nowadays using. And just like there is always time for pain, there is always time for healing. So we have a lot of techniques now available to control this chronic pain and give relief to the patient. So we have now, initially we have conventional radio frequency ablation, now we have cooled radio frequency ablation, and now we have cryo also. So there are a lot of development happening in the field of pain medicine to give good pain relief to the patient. So when we talk about the chronic pain, it's a public health problem, and this nuisance of chronic pain results in serious negative economic consequences due to disability and cost therapies. So there are a lot of issues of chronic pain. What we are treating is just tip of the iceberg, and a lot of patients are still missing this facility of pain management, and they're suffering from this chronic pain. There are a lot of techniques as discussed by Dr. Dhruva and Dr. Gautam Das. That there are various techniques by which we can give pain relief, like physiotherapy, even the pharmacotherapy, and now the intervention therapies. In that, we have some, as commonly, there are 3 modes of neuroablative technique, like radiofrequency, which is a heat neuroablative technique. Then what we are doing, chemical neurolysis, and then cryoablation, as was telling about. So when we talk about the radiofrequency ablation, this is an old technique. Shelley used it in the facet joint in 1975. Commercially, it is available from 1950. So what is the mechanism? As Dr. Dhruva was telling, the radiofrequency technique consists of electrically generated source applied to an insulated electrode. So when we are putting that electrode, it's insulated and the tip is active. So ion attempts to this high frequency causes the friction of the ion inside the tissue, and that generates the heat. And whatever the temperature we are looking at is actually at the tip. It's not the actual tip temperature, but it's a tissue temperature. So the radio frequency probe has a thermocouple. Actually, that's why that technology is very costly, because that thermocouple technology is itself that innovation itself is a costly thing. So there is a thermocouple in the probe that will take the exact temperature at the tissue level. So heat is generated in the tissue from this high frequency change, causes the change in the direction of and causes the friction in the ions. The average temperature generated is between 60 to 80 degrees Celsius, and the size lesion produced is dependent on the size of and the diameter of the lesion, along with the temperature generated. But the independent of increasing the time interval. That means if you are keeping the temperature, the time as 90 seconds, even if you increase to 100 seconds or 120 seconds, the lesion is not going to increase. So there are a lot of literatures available to show that the maximum temperature you can achieve is from 60 seconds to 90 seconds. So this is a common probe of a radio frequency with the insulated this tip, which is active tip, and the whole needle is insulated. So these radio frequency probes are able to generate heat in the surrounding tissue through ionic heating, and radio frequency energy radiates throughout the surrounding tissue. Ions like sodium, potassium chloride present in the tissue will oscillate, and the friction results in ionic movement generates the heat, which is the cause of thermal destruction of the nerve. This is the most important, that we have that thinking that because of the electric current, the tip will get heated. It's not like that. So what is the difference between the conventional radio frequency and cooled radio frequency? So we will go into detail. So the key limitation for the standard radio frequency ablation is charring of the tissue, as Dr. Dhruva was telling. So even if we increase the duration, it will start charring, and whenever there is a charring, that charring will act as an insulation. So the tissue, beyond that lesion, the tissue heating will not happen. Even if you increase the time, there will be charring around this lesion. So that is the biggest disadvantage of limiting the size of the lesion with the conventional radio frequency. So the people came with the cooled radio frequency ablation. So what is the cooled radio frequency ablation? Whenever it causes a bigger lesion as compared to smaller lesion by the conventional radio frequency. Why this happens? So that is a technique. So because the size and shape limitation associated with the standard radio frequency ablation, it can be difficult to reach to the desired nerve target. So when we are talking about the middle branch for the facet, then the size of the nerve is very small. So you are not sure whether you are going to ablate that nerve or not. So they came up with this cooled radio frequency. What is the advantage of cooled radio frequency? There is a water flowing through this channel. So water is coming through this channel and going away. So it will take away the heat, and the lesion will spread around the tissue, and it will create a bigger lesion like this. So the circulated water serves to carry the heat away from the tissue interface, which will reduce the desiccation and subsequent charring of the adjacent tissue. As such, cooled radio frequency ablation is able to deliver more energy to the surrounding tissue, creating the larger area where the ionic heating can occur. The cooled radio frequency ablation sets a temperature it's around 60 degrees, and studies have shown that major temperature beyond the tissue interface reaches up to 80 degrees Celsius. The larger spherical lesion shape can provide more extensive denervation, and larger lesion can produce the likelihood of missing the target nerve. So that is the biggest advantage. Even if any junior who is performing the cooled radio frequency ablation, chances that he will ablate the nerve are high when he is using the cooled radio frequency ablation. So there are various kinds of different length of the cooled the needles are available. Active different kinds of needles are available. So there are various kinds of needle available, and the average size of the probe is 17 gauge. It's a very thick thing, and the needle is also bigger in the cooled radio frequency ablation. So electrode itself is 17 gauge in diameter with the electrode varying length and tip. So whenever we are using the which tissue we want to target, depending on that, we have to choose the size of the needle. So the appropriate electrode length and tip size used is dependent on the depth of the target and the desired ablation zone dimension. For cooled radiofrequency ablation of the glenohumeral joint, typical an electrode with the length of 75 mm with a 2 mm activity. The cooled radiofrequency ablation of hip, typically the electrode is 150 mm with 4 mm activity. And this in the SI joint, I use this 7.5 with 4 mm activity. So what are the imaging indications? The indications are particularly geniculate nerve ablation of the knee, articular branches of the shoulder as well as hip, sacroiliac joint, lumbar facet, discogenic pain. In cervical and trigeminal, this is not recommended. So what are the advantages of the cooled radiofrequency ablation and what are the disadvantages? We will just discuss this thing in the brief so that we can have just an idea about when to use the cooled radiofrequency ablation. So the advantage of cooled radiofrequency ablation is the bigger size of the lesion. Technically, it is easy. As Dr. Dhruva was telling, when you are using conventional radiofrequency, the probe and the nerve should be parallel, so that you can create a good lesion in the nerve. So that is technically sometimes when you are doing for the facet, technically sometimes it's very difficult to align your, if you are not very much experienced, to align your probe along the parallel to the nerve. So it is technically difficult. So when you are using this cooled radiofrequency ablation, you can be perpendicular to the nerve and you can create a bigger lesion so that you can ablate the nerve. And it gives, because it creates a bigger lesion and the region is very good. And as sir was saying, maybe it's grade 3. So the duration of pain relief is much more when you are using cooled radiofrequency ablation. The disadvantage is that it's not cost effective. As sir was telling that it is the cryo is. I was not aware about that cryo is cheaper than cooled radiofrequency ablation. I was thinking that cryo is much more costly than cooled. But definitely the cooled radiofrequency is not cost effective because the kits itself costs around 32,000 rupees. The availability in smaller cities, maybe it's an issue, and it is not suitable in certain areas like trigeminal neuralgia. For the trigeminal nerve, gastric ganglion, we can't use this. Even for the cervical facet medial branch, we can't use because of the proximity of the nerve root near the medial branch. So we have formed. The sir was heading this society, which formed the ISSP guidelines, and we have come to some consensus where to use this cooled radiofrequency ablation. So we were around 8 or 9 pain physicians came together and we had meetings and we discussed that thing in, I think, in Ahmedabad conference also. So consensus for using this cooled radiofrequency ablation is mostly in the OME and sacroiliac joint, lumbar facet, and intradiscal, that is baculoplasty. So these are the ISSP guidelines. So this is how you can use this cooled radiofrequency for the hip, for the genicular nerve, and for the sacroiliac joint. So for the even for the shoulder, there is one nerve is missing where we ablate the articular branch of the axillary nerve here. So this is how we can do the cooled radiofrequency ablation. And I use different technique, as sir was telling. I use the carpet region technique, like a leapfrog technique for the sacroiliac joint, so as to ablate all the lateral branches and get a good pain relief for the sacroiliac joint. I am little scared of using the cooled radiofrequency at this table as S1, S2, and S3. I am very comfortable using at this level. So this is the kit of the.
Sir, you are on mute. Okay. I have sent you the prompt, sir. Please unmute. Uttam, sir, we are not able to listen to you. Hello. Hello. Ma'am, can you call him on mobile? Hello. Uttam sir, we are not able to hear you. Please unmute. He just went on mute. Hello. I'm sending him prompts repeatedly till he unmutes himself. Hello.
Yeah, I've asked him to restart from the.
Yeah.
Hello.
Yes.
Hello.
You have shared the screen. Yes, sir. You are audible now.
I'm audible?
Yeah, you are audible.
Okay. And from which side I was?
Video. Sir, again you went on mute. I think while starting the video, there is something happening. You are going on mute. Hello, Uttam sir. Please unmute. Hello. Yeah.
Hello.
Yes, sir. Now you are audible.
I can't hear you.
You can't hear me now? Varshali ma'am, can you hear me?
Yes, we can hear.
I can hear you.
Yeah.
So there might be problem of Uttam. Uttam, you just check your microphone and the speaker.
Hello.
Uttam, we can hear you.
But he is not able to hear us, sir. So he is speaking. But
Maybe his speaker is not working. Or maybe speaker selection is sometimes.
And I think it is one at a time. The moment he started video, he was muted. So there is some connection, syncing.
Yeah, he will do the needful. I've communicated to him and he will. Yeah.
Thank you.
Can you hear me?
Sir, yeah, we can hear you now.
I can't hear you.
Okay, there is some error in your audio system, sir, probably. You have to talk to him on phone, Varshali madam, again. Okay, maybe he can stop playing the video and speak about it. Just if you can request him. The moment he starts video, there is some problem.
Hello.
Yes, sir. We can hear you. We can hear you.
Hello.
Hello.
पण मला नाही ऐकू येतं तुमचं.
Okay, but you carry on ना आम्हालाच ऐकायचं.
Okay, ठीक आहे. So the video I was showing was just a demonstration how the kit is there and how the machine works. So the rotating the things you were seeing that rotator propel the fluid through the cannula, and it travels through the cannula, takes away the heat, and that creates a bigger lesion.
You can stop sharing the screen. You have shared your screen and not the video.
Hello. Can you hear me?
Yes, sir.
I can't hear you. I can't hear you.
But you share the presentation and keep speaking. I'll just put in chat.
Hello.
पण मला काहीच ऐकू येत नाही.
No, definitely. Once he starts video, no, madam, he is going on mute. So it is synced.
I know. Anyway, he said that he has done so.
Yeah. I have sent the prompt of unmute, sir. Yeah. I am only seeing on your screen now. You have shared this screen. Yes, Shete, sir. I will unmute you. Yeah. I'll unmute everyone now. Okay. You can unmute yourself. Yes, sir.
Hello.
Uttam.
So, yeah, can you hear Dr. Uttam?
He is not able to.
Hear. No. Fine. I think we will start with the at least some discussion till he fixes his audio. So the cooled RF, as we all know, is one of the recent techniques which is being used and has become popular because of the size of the lesion, which is very important, and that's what Dr. Uttam was trying to explain to all of us, that because of the cooled effect around the probe with the distilled water or normal saline which is being used, the temperature which we can achieve is much higher, and the size of the lesion becomes higher. You can hear us? No? Right. So till here, if there are any questions related to cooled RF, I think we have Dr. Varsha, Dr. Varshali, myself, we can answer them. Are there any questions?
No questions, I guess it was.
Fine. So just to complete the discussion, the cooled RF is very common and useful technique, especially when we do genicular RFs, especially shoulder and around the knee joint. The reason is the knee joint has no particular one nerve which supplies it, but let's say a plexus of nerve which goes there. And it's very difficult that if we use a single 10 millimeter size probe where we use it for medial facet branch. So we need to have a little larger region to achieve the pain relief, especially when we are going for medial, superolateral, and the inferomedial part. And that's why cooled RF helps a lot, so that you can have larger area and larger nerves can be ablated. Similarly, it works for the shoulder as well. In terms of we have to be sure about, of course, as any RF technique, we have to do diagnostic block first, make sure that there is adequate at least 50%. Principles remain same as they remain for the conventional RF, where Dr. Dhruva presented it, the radio frequency. One more thing, the cooled RF works very good, especially for SI joint. The results of doing conventional versus cooled RF, I have myself experienced, a major difference for the pain relief. The duration probably might remain the same, but the pain relief achieved is much better when we use cooled RF for sacroiliac joint. In fact, Dr. Uttam has done quite a lot of work into sacroiliac joint and cooled RF. Maybe some other time during our, I think, conference, we can make sure that he has that presentation there. So I think we are now getting delayed as well. So I'll conclude this session. I would like to thank everyone for attending the session and all the presenters. I'm sure there are many more questions which keep coming, but you can ask them anytime during our conversation at conferences. And I invite all of you for our annual conference next year, which is being held in Pune. Our Pune team is really working hard to make sure it is the best academic experience as well as extra academic experience to all of you. Over to Dr. Varsha for a vote of thanks.
Okay, thank you so much.
Before Varsha says, I would like to, Varsha, I would like to thank all the speakers, Dr. Dhruva, Dr. Gautam, and Dr. Uttam, and Dr. Shete. You really connected everybody quite well. As usual, thanks Varsha and Varshali for bringing us feast every time you arrange some program. So great, this thing.
And thank you, ma'am, for making time and being here with all of us. Okay. And I would really like to thank Dr. Dhruva, Dr. Gautam Das, and Dr. Uttam Sidhaye, especially on a very short notice. We came up with this program, this theme, and we wanted this speaker, and we got yes. So thank you, everyone, for giving us great insights and making this interactive session for everyone as a different experience. And I would like to thank Mr. Chobe and Anesthesia TV for taking this session on 5 different platforms at a time and making it available for more than 1,000 of audience live and later also. And I would like to thank our technical team and SSPP organizing team for making it possible and making the flyer and spreading it all over. So thank you, everyone, and have a great week ahead. Okay, can we conclude, Varshali ma'am?
Yeah, thank you, Das sir, Dr. Dhruva and Dr. Uttam for such a wonderful session. It's always a pleasure to listen to stalwarts. Yeah, and the YouTube will be available. We have our SSPP channel, YouTube channel. So all the academic sessions so far can be accessed from YouTube channel.
I'll just post the
so
link.
We can listen again and again. Thank you very much. Thank you for all the interesting discussions. Yeah, Varsha, we can conclude.
Okay. Bye and good night.
Bye-bye.
Bye. Good night. Thank you, Dr. Kiran Shete.
Thank you, ma'am.
Yeah, sorry. Thanks a lot, Dr. Kiran. He's our family. Yeah, I forgot to thank him. Right. Thank you.
Bye-bye.
Bye.